Good evening, everyone. Just give us a few minutes. We're going to start about 5 past. You need a mask.
Say party that's sparking questions of perhaps a future leadership role for Batia. We are
Go on, baby, go on. Hurry up.
in front of us. The
Good night. Now I gotta stop. Good evening, everyone. We are about to get started. I am so excited to see all of you here with us this evening, and I trust that you had a good day. I am Dr. Monique Mitchell, and I sure you could see me in my green, right? Yeah, y'all could see my green. So today, this month, actually is Kidney Awareness Month. And so we're very, very happy to have a meeting, and we're going to be covering that topic. So we're going to get started. Seeing this. All right. Hold on one second. I see somebody on my screen. I'm trying to figure out who that is, but I will continue admitting until I can figure that out. All right, so let's get started. I am so excited. I even see some of my kidney friends are here. And so we are gonna get started. Thank you so much for being here. Tonight is Thursday, and we are here at the Feet4Life Diabetic Online Seminar. You know, we have this monthly, and I'm telling you, it is going so fast. But we are excited to be here tonight. Happy Thursday, and hope that you have a good day. And thank you for joining us. We want to send a special welcome to all of our first-time visitors or attendees. We just want to say a special welcome to them. Please remember to mute your mic and also to put your questions in the chat. Well, tonight we have an exciting program for you, and I'm sure you're going to have some questions. So from the very beginning I want you to write your questions down and have them ready to go because we're going to be answering every question tonight. We're not postponing any question. So we are also live streaming on Facebook. So if you want to invite somebody to come and watch us or stay with us, you can do so. We have all of our recordings on YouTube now, and it's at Feet, the number 4Life 242. You can go to that channel and you can subscribe and follow us, and you would not miss any of our presentations. So tonight, we also invite you to write where you're joining us from. We'd like to welcome everybody and we'd like to recognize where you are joining us from. So in the chat, we want you to write and put what island or what city or what country even you are joining us from, and we will be happy to recognize you. So I see our first person already. Nassau already represented. Nassau is right, definitely. Put that in the chat and we will recognize you. You know, if our regular attendees, you know, we begin with a devotional. And so tonight we will do the same. And we have with us Pastor Lyndon Williams, who will bring our devotional. He is a pastor, a husband, and a father, and he has been in ministry for 32 years. Wow, Pastor Lyndon. I didn't know you were that old. He's just looking at me in maturement. But Pastor Williams, he is, like I said, a pastor and a father. He is currently serves at the Ephesus SDA Church, and he also serves as host for the radio show Focus on the Word. He has a Master's of Arts in Pastoral Theology, and he describes himself as a knowledge junkie, a nature lover, and a technology enthusiast. Let us welcome Pastor Williams as he brings our devotional and our prayer. Thank you, Dr. Williams, for being here.
Okay, good evening, everyone. Thank you. I'm Dr. Mitchell. I
We can
haven't
hardly
gotten a
hear you.
job.
Can you go a little louder? I'll turn up my
Okay.
as well. Okay, go ahead.
Is that better now?
Yes, that's much better. Go ahead.
Okay, yes. You said Dr. Williams, but I have specifically not gone after doctorate degree for a simple reason. One of my lecturers in college told me when you get your bachelor's, you think you know everything. When you get the master's, he says you find that you don't know half as much as you thought you did. Said when you get your doctoral degree, that's when you realize you don't know anything at all. So I'm going to stay at the master's level so I can continue fooling myself that I know something. So no doctorate for me. But be that as it may, I'd like to say welcome everyone, and I want to turn your attention for a few moments to the Gospel of John, chapter 5, where the paralytic man is healed. And I'm going to sort of pick through this very quickly. It's about 17 or so verses. Jesus is walking in Jerusalem near the pool called the Sheep Gate Pool, which has 5 porches. And they had a lot of lame persons, blind, the sick, whoever, were all gathered around this pool. What is interesting is that he sees a man who has been there 38 years. Now remember, the text says in verse 3, and these were lying a large number of those who were sick, blind, lame, paralyzed. Jesus focuses on this one individual, and then he asks a question. And I'm glad that gentleman was not from the Bahamas because he would have said something, even if he only said it underneath his breath. Jesus asks, do you want to become well? Oh, here we go. Says, do you want to be made well? If it was a Bahamian, it'd be like, duh, what do you think? You think I'm just here to catch a suntan or something? The man says, I have no man to put me into the water, into the pool when the water stirred up, but while I am coming, another steps down before me. Jesus then says to the man, and here's the kicker, rise, take up your bed and walk. It would have been easy for the man to say, well, could you help me? Could you give me a little hand? I've been in this way for 38 years. If I could get up and walk, I wouldn't be here. Somehow his faith reached out and he got up and walked. Now, I always think about this. There's something called muscle atrophy. I think I pronounced that correctly, where when you don't use your muscle, the muscles in the leg, let's say in this case, his leg, would become weak. They lose their strength. If you've ever seen someone wear a cast on their foot, which was supporting, when they take it off, I remember I had a friend of mine like that. The leg muscles are not strong enough to hold them for an extended period because it has to be re-strengthened because the cast was helping to support their weight rather than the foot itself. And this man had been in this condition for 38 years. Have you ever seen someone who lost the use of an arm or leg in a very short space of time? You will notice that particular limb begins to shrink. It's not as healthy, it's not the same as strong, it's not as large as the other one because it is not being used. And this is what would have happened to him 38 years. So now imagine with me what was happening in this man's body, Dr. Mitchell. All of a sudden, at the word of Jesus, cells started multiplying, they started repairing themselves, blood started flowing in ways that had never done before. And all of a sudden, cells start joining cells together. This one started to expand. All sort of things were going on at the cellular level. And this took place in about a second. Jesus says, take up your bed and walk. And what happens? Immediately, verse 9, the man was made well, took up his bed or his mat, and he got up and he started walking. Now, I don't know what all he did, but I think I would have been skipping. I'd have been jumping. I'd have been doing a Holy Ghost dance. I don't know if it was the mashed potato or the veggie mash or something, but after 38 years, yes. But this is the God that we serve. Very often he works through healthcare professionals like Dr. Mitchell and others. But then sometimes when he chooses to, he works a miracle in a way that we have not seen before. And this took place at the beginning of the formation of the Christian church, we would call it. And it's believed similar miracles will happen toward the very end of time to distinguish those who are in a relationship with God and who are doing his bidding. So, if God could give you a miracle today, what would it be? A miracle for your body, healing for your body. What would you ask him to do? Well, Christ told the paralytic, take up your bed and walk. Physically, but spiritually, I believe he wants us to also walk and get up from the spiritual stupor that we may in, the paralysis and so many things that affect our spiritual life, that we are not who he wants us to be. So let's determine to rise up, take up our bed, and walk. Let's pray. Father in heaven, thank you for the opportunity to go into your word. Thank you for the healing power that the Savior brings. He also commands us to take up our beds and walk. They may not be physical beds of affliction, but in many cases, they're spiritual affliction where we have become lackadaisical, where we have become despondent. Some have simply become cold. Christ is telling us to take up our beds, to walk in newness of life. By faith, may we grab a hold of that promise, that we may be able to glorify him and the world may know that he is the Son of God. Bless us, we pray, in Jesus' precious name. Amen.
Amen. Amen, Pastor Williams. Take up your bed and walk. That is a powerful devotional and a message that many of us need to hear. And it's a reminder and an encouragement to many of us to take up our bed and walk. To me, I interpret that as doing what I can to help heal my body, and Jesus will do the rest. So thank you so much, Pastor Williams, for that powerful devotional and reminder. So this evening, we have our chat is filled with persons who are joining us. So we have persons here, of course, from New Providence, all over New Providence. Nassau East, I see Fleming Street, Nassau, everywhere, north, south, east, and west in Nassau, New Providence, Fleming Street Clinic, South Beach Clinic. I don't know, we have a whole bunch of nurses on tonight, right? Registered nurses, TCN. So awesomeness. Thank you all for joining us. Sunderland as well. We also have persons from Grand Bahama. We have persons from all over New Providence. Like I said, I see Andros here. I see Turks and Caicos here. I see Florida here. We even have a midwife on a nursing agency. We have Dr. Taylor from Florida. We have Andros. We have Turks and Caicos. Oh my goodness. Thank you all so much for being here. Thank you so much for being here. Grand Bahama always well represented. So definitely kudos to Grand Bahama. So just continue putting in the chat. If you didn't put in where you're joining us from already, just go right ahead and do so. We're going to get started. So for persons living with diabetes, foot complications are some of the most common, most costly, and most feared. In a recent article or study performed by the International Diabetes Federation, persons who have living with diabetes actually showed that they feared amputation more than death when they did the survey. But about 25% of persons with diabetes will experience some foot complications sometime in their life. We know that when it comes to diabetes, seconds count, not minutes, not hours, not days, seconds count. So every 1.2 seconds, someone develops a diabetic foot ulcer. Every 7 seconds, someone actually dies from diabetes or complications of diabetes. And every 20 seconds, someone gets an amputation somewhere in the world due to diabetes. So we see that every second actually counts. Here in the Bahamas, as it is around the world, complications from diabetes are increasing, especially foot complications. And tonight we will hear a lot more about kidney disease and as a complication of diabetes as well. And that is also increasing here in the Bahamas. But so we wanted to do something about that. And that is why we are here on this Zoom meeting on a regular every month meeting, talking about how we can prevent these amputations and these complications. Well, it is March and it is Kidney Awareness Month. So I'm wearing my green, and I hope you have something green close to you as well. It could be a green smoothie if you want. That's anything. But a green, something green. But if you don't have it tonight, definitely sometime this week. And I see Sister Tamika, who is president, Tamika Roberts, who is president of the Kidney Association. She is here with us, so I will give her a moment a little bit later if she's still here to bring some greetings as well as to give us a little bit more about what's going on and what you can do to raise awareness about kidney disease as well. So this month is Kidney Disease Month, and we are going to be tackling that topic as it relates to the feet. Our speaker or our interviewee, we are going to have an interview session with Dr. Freddy Smith, who is well known to all of us. He is a renowned internal medicine doctor and nephrologist. That's a kidney doctor or kidney specialist. And he is highly educated and well educated and highly qualified to speak to us today on the topic of kidney disease. He has been in the field for over two decades now. He has began his training actually, and very impressively, I didn't notice for him, but his undergraduate was in chemistry. And he did that from St. Augustine's College. If you didn't do anything else, kudos from me for that one. Because me and chemistry didn't go too far. But excellent job. He completed his medical education at the University of the West Indies. And then he also went on to get a doctorate in medicine, in internal medicine, also from UWI. He then went on to do a fellowship in general and transplant nephrology in Halifax, Nova Scotia. He returned home, praise the Lord, and is now working as a consultant and the medical director for the dialysis unit at the Princess Margaret Hospital. He's also an internal medicine and nephrology specialist at the Bahamas Surgical Associate Center. He will tell us all about kidney disease in the Bahamas, how it is treated, how it can be prevented, and also to give us a little bit more about the relationship between kidney disease and feet. We will also talk about that, especially for those persons who are on dialysis. I am so happy that you are here because it's more than 60 of us here already. I'm so happy that you are here because you do not want to miss this. This is going to be a lot of information and good, powerful information that will help you and whoever you love and your family members to live a more healthy life. So let's use our reaction buttons here and let's send up our emojis and welcome Dr. Freddy Smith. We're going to have an interview style tonight. And so we're going to have him open his camera and his mic, and we're going to get started. We'll bring us some greetings and tell us a little bit more about himself if he wants to. And then we're going to start with our questions. Welcome, Dr. Smith. Thank you so much for being here with us.
Well, good afternoon, good afternoon, good afternoon, or I should say good evening.
Good
Dr. Mitchell,
evening, good
I see
evening.
you there in your green, Dr. Mitchell. Now, your green is
Yes,
closer to it than my
yes,
green is, but we
yes.
represented.
Representing. So
All
yes,
right.
Dr. Smith, we're very, very happy that you are here. And it's been a while. And I think this is your first time coming on. So we're very pleased that you're here. And we have about 65 persons on tonight. So we're very, very pleased that you're here. We have make sure, I gotta say, Illusion is in the house. Make sure say that. And then we have Twynham Heights, Nassau East. Okay. So another TCN. Okay, so we got all nurses here tonight. Right.
Well, the truth is, then you don't need me because you got them because they do more of this than I ever do in my life.
Okay, so we're going to get started. Our first question, and so we're going to do this like an interview style. So our first question is, Dr. Smith, we would like for you to give us kind of an overview of the scope and the problem that we have with kidney disease, maybe internationally, and then bring it down home into our neck of the woods. Can you give us a little overview of what we're dealing with in 2026 as it comes to kidney disease?
It would be my pleasure, but could I just put up the Baptist finger and say one thing before we get started?
Yes, sir.
So, what I appreciate you. So, first thing, I thank you for that dearth of compliments that you gave me as in starting in my introduction. But guess what? I'm not the boss in the dialysis unit at PMH no more. It's Dr. Thurston Carroll. So,
Oh,
for
sorry.
director, Dr. Thurston Carroll at PMH,
Listen, Carol.
you say, well done, Dr. Thurston Carroll, and thank you for your leadership.
No
And then
problem.
second, and then I'm going to say one more thing. So, Pastor talk, and he say
Mhm.
he is not the doctor. But he's quite right, the more that we hold on to that term doctor, the more we realize we don't know as much about what we thought. So maybe I should have kept hold on to that bachelor's as well. But it is what it is. It's a little
Yeah,
too late now.
too late.
So and I'm gonna go to your question, and I'm just gonna say again. So I heard you talk about Ms. Roberts there from the Kidney Foundation, and again I want to say welcome to Ms. Roberts and thank her for joining us. And then even before I start, I want to support the Kidney Foundation because again they do lots during the month, and there are other units that do lots during the month as well. I know that Kidney Center does some sessions, and some of the other units too, but I call them out by name. The national because I also know that the Kidney Foundation about to have this little soiree. So we're all looking for our green. You're all looking for your green dresses. I'm looking for my tuxedo and my bow tie. So we'll be happy to sit in and support that. And then again, just before we start, today is World Kidney Day, right?
Hey, the actual day,
And
the
it is that day,
actual
it's the
day.
12th of March, World Kidney Day. And truth, just as we started, we're going to say the theme, and every year they have another theme, So one year they talked about water intake, they talked about kidney health, and this year the theme is kidney health for all, caring for people and protecting the planet. So I think that says a whole lot, and forgive me because I'm not the one who delivered the word. We can leave that to Pastor and the doctor, Reverend Pastor, who say he ain't the doctor anymore because truthfully he knows more than what he's letting on or he's sharing with us. But truthfully, it does go back to the whole thing about healing and health, eh? It goes back to the whole thing about thinking about atrophy. And Doc, yes, I'm sorry, Pastor, you did pronounce it correctly. We do talk about atrophy. If you don't use something, you lose it. It shrivels up and it doesn't work. So I'm going to say that a little different for kidney health. So truthfully, I think that we abuse kidneys, and because we abuse kidneys, then they atrophy and they shrivel up and we don't have their benefit anymore. So in talking about worldwide, and talking about worldwide statistics, we do know that they can continue to say that the number one cause of kidney disease is diabetes. The number two cause of kidney disease is diabetes. And truthfully, there is even the little flip of that now, where sometimes they say it's hypertension, sometimes they say it's diabetes, but one and two kind of flip flop between each other. And then what we're seeing in even more than that is we're seeing that non-communicable diseases such as metabolic syndrome, obesity, dental caries are now trumping on top of diabetes and hypertension and becoming even more prevalent as causes of kidney disease. Dr. Mitchell, I love that statement that you made in the very beginning, second save feet or second save limbs. So, truth, I want to adopt the same thing for kidney disease, even though I don't have those specific statistics. I will say that doctor's visits and regular checkups save kidneys. I would say that lifestyle changes, loss of weight, a little healthier weight, more water, cut back on your carbs so you don't develop the diabetes, you don't have the obesity, save kidneys. I want to say that decrease in alcohol, I want to say the decrease in nicotine use saves kidneys because we do know that nicotine damages blood vessels, and overall, kidney health is married to vessel health. And hence it's married to loss of limb. Because if we don't have good vessel health, and watch this, I'm going to see if I can make a connection here. If we have lots of sugar or we have high blood pressure, it damages the blood vessels. If it damages the blood vessels, it means the flow to the kidney is not as great as it should be. And then a kidney that is a normal size then starts to shrink down because it comes ischemic. Similarly, too, if you have blood vessel problems, then the most distal part of your body, the fingers and the toes and the feet, start to develop ischemia and they start to get ulcers. And so we do know that vessel damage causes kidney damage. Kidney damage is associated with vessel damage, and it's also associated with loss of limbs, depending on what the comorbidity is. And in this case, most times, diabetes, number one cause, if you look at it, and then flipping it to obesity. And we know that obesity causes vessel damage too, eh? So how many people have we known that have these Bahamian fluffy, Bahamian sexy kind of physiques and that sort of thing? And then you look at them and they walking a little funny. And they don't want to take off their shoes and their socks in public, why? Because they start to develop ulcers, stasis ulcers, which could be associated with kidney disease as well, because when you develop kidney disease and the legs start to swell, then you kind of get that fluid down there and you get those stasis ulcers. So again, I want to say, just how you will say that we have the potential loss of limb in seconds and every second counts. I'm going to say every year and every visit to your doctor counts in terms of kidney health and preventing loss of limb, as well as loss of organ, as well as loss of life and death.
Technology, arts and culture center.
Amen. Amen. Just want to remind you to mute your mics as Dr. Smith is doing his presentation. We're chatting. Unless you have a question, if you have a question, you can just raise your hand and I'll be happy to recognize you. And then we will recognize you. I will invite Sister Mr. Mika Roberts at this time. If you wanted to add anything else to the question that we were talking with Dr. Smith at this time, Ms. Roberts, you can unmute and we'll allow you a few minutes to give your greetings. I don't see her. Is she still on? Okay, yes, I hear you.
Yeah, I am on. Thank you so much. Thank you so much for
Go right
having me.
ahead.
Yes, this is definitely an exciting time for the Bahamas Kidney Association and the kidney community at large. And so, Dr. Monique, I commend you and your team for putting this on. Kidney disease, we see it as a silent disease. It's under-recognized, and definitely more needs to be done. More awareness in terms of persons knowing what are the signs, making sure, like Dr. Smith would have said, get their checkup and all that stuff. So we definitely stand in support of you and the work that you're doing. And you would have come to the association a few times and speak to the kidney patients about their feet. And so we support the work that you're doing, especially today, World Kidney Day. We are very excited. And so I could not miss your meeting, even if I wanted to. I just came out of a meeting, but I said I must join your meeting. I heard Dr. Smith put in his plug. Dr. Smith, don't worry, your seat is saved. So make sure you have on your green tux. I don't know where you're going to find it from, but make sure you have on your green tux for the 28th. We do have a lot of events going on. Actually, even on Saturday, Dr. Monique, we have a similar session that will be taking place at UB. We're going to try and get it to air live as well. And it'll be talking more about the kidneys, living donation. As you know, we would have just done one locally in June. So all of that good stuff. We also have a cooking session for anyone that is a kidney patient, a renal patient. You want to learn more about how to prepare these meals. That is on Sunday as well. I won't take up too much of your time, but I want to thank you for giving me this opportunity to put in that plug. We have our first fundraiser on the 28th, which is the Emerald Soiree. And trust you me, we are sold out. We are sold out for that event. And so we are happy to know that Bahamians are interested. That shows that Bahamians have a concern. They are interested. They want to know more. And hopefully, by knowing more, we can reduce the instances of kidney failure within the Bahamas. So thank you, Dr. Mitchell.
You, Ms. Roberts, you didn't mention the association. Just put a little plug in for the association.
Of course, anyone, the association, we are located, we have a building, we have an office, we are on Mount Royal Avenue. We also are selling t-shirts and other paraphernalia for the month of March. We are encouraging persons that are on dialysis. If you need assistance, the Bahamas Kidney Association, we offer 4 medications for free to persons enrolled in our program. One is the TUMS, the calcium carbonate, the Neprovite, the Nepro, and alpha calcidol. We are looking to expand this, but definitely we can only expand based on our donations from the general public. We are a nonprofit organization, so we also encourage those persons who can to donate and to support our cause and to support our initiatives. This last year, actually, we donated a dialysis machine to the Princess Margaret Hospital, yes, through one of our corporate donors, and we were very excited about that. We have some other things that are in the pipeline for a donation to Princess Margaret Hospital. So we're excited about our give back, even to persons in the community. And so please, we ask that you would join us, follow us, like us on Facebook, Instagram. We are even on TikTok. We have high school competitions going on for the children during this month. Essay competition, TikTok challenges, dance, a lot of activities surrounding kidney health. So please follow us, like us. We have a website. You can reach us at 436-1317, 436-1317, or if not, Dr. Mitchell definitely knows how to get in contact with me. Thank you so much, Dr. Mitchell.
You are most welcome. Thank you so much for being here and being willing to speak. Like Ms. Roberts said, I had the opportunity to go to the Bahamas Kidney Association meeting, and every time I go, it is just an eye opener. And it's a pleasure to go there and help educate the persons, do some screening, and we definitely have some works in the pipeline that we'd like to continue. So thank you so much, and I might miss the soiree this year, but I don't worry. I'm getting ready. I have my green dress. So I'll be there. I'll be there. So let's go on, Dr. Smith. So tell us a little bit more about I don't know if you have like actual numbers of persons who are on dialysis or who are actually showing their, hold on one sec. Let me see who that is. Okay. Thank you. All right. So Dr. Smith, I don't know if you have like actual numbers so persons can have like an idea of the scope of the problem in the Bahamas, like how many persons do we have on dialysis or how much persons are affected? And then tell us a little bit about kidney disease. How does it develop? And then what is the different stages of kidney disease? So persons will have a clearer understanding about it.
Okay, so I'll start by this, I'll start by saying this. So actual numbers for the Bahamas, I really can't say what the actual numbers for the Bahamas are, but I can say that we do have a clinic, and I can just use the public sector as a marker. We do have a clinic that's on a Thursday morning at Princess Margaret Hospital, where there are 3 nephrologists that are there that take care of the population that comes in. There is the senior of the group, Dr. Ilsa Grant Taylor. There's a fabulous current director, who is Rhea Thurston Carroll. And then I stand at the bottom of the door, and I'm Frederick Smith. And typically on a Thursday morning, we can see anywhere from about 30, 35 people between the three of us easily. And if this stands to reason, people keep saying it takes long to get into PMH and do things. So with the three consultants seeing over 30 patients, over 10 people in a clinic, honestly, people may say that's not a lot, but I think it's significant. You will find that at times the wait period to get into the clinic could be 3, 4 months or even longer than that. So it's telling you that there's a large burden of kidney disease out there. I think we're seeing more kidney disease because and as I had a little teaching session with the patients this morning, I told them they should stop looking at people and the first thing they saying is they fat and you look like you put on plenty weight. Why are you so fat? But the reality is that we have a high burden of obesity in our country. Even what we consider as normal is probably a BMI greater than 30 by most standards. We have a high incidence of not just looking at the BMI, but if you look at a male, so they say that if you wear a shirt that's greater than a 17.5 neck, it's probably too big. It puts you at risk of metabolic disease or metabolic syndrome, a part of which is impaired glucose tolerance or impairment of your sugar regulation. And that's a size large. Most of us that are out there doing large, extra large, 2X easily. And guess what? Everybody's still looking at us and say, hey, that dude look good. So I think we have a perception of what normal is that needs to change. So I think the very first thing that we need to do to prevent kidney disease or slow down kidney disease is change that perception of what normalcy is. I think that I've said this a couple times, and Sister Sarabe, if she's on the call, would stand to reason from her in a group that I keep putting the plug at, that most people think that a healthy baby is a big baby. If you have a small baby, then they say that's a bad mommy and they ain't feeding that child, feed that child up some more. But truthfully, a big baby or a child that's over that 90th centile is an overweight baby and putting themselves at risk of kidney disease and throughout life putting themselves at risk of peripheral vascular disease, because we do know that obesity plays a role in that. So I think that is a big kind of concept, right? And I see somebody in the group say it depends on if this is a European large or this is a Chinese large, and I don't mean that in any derogatory term. It depends on where it is made, and I take that. There are norms throughout societies, and some larges are not realized, but I'm talking about the average
Very large.
large that is there. I'm talking about not the modern size, which is oversized. I'm not talking about the slim fit. I'm just talking about the natural large that gives you a 17.5 neck. Okay. So I'm not even going into the different markets that we speak about. So I think that's a point number one. So I think that it goes back to lifestyle changes from the very beginning.
Okay.
So if you go back to numbers again, it suggested that there are over 5 million people in the world that have diabetes, hypertension, and kidney disease. It suggested that anywhere between 3 to 4 to 7% of those people will go on to end up with end-stage renal disease or kidney disease because of it. So 7% of 5 million is plenty. Unfortunately, we in the Bahamas, I think, are mirroring that same pattern. We are following the North American trends. And again, Sister Saturday, if you're there, I've quoted this for years and years as we've had this talk. Dr. Sawyer did a paper, an article in one of the, I can't remember if it's the Guardian or the Tribune, years and years ago, that echoed that same sentiment. What we are following is the North American trend. So let's think about 7% of our 400,000 people will probably end up with some sort of disease. All right. So we do have a very large population out there of kidney disease. What are the symptoms of it? I see somebody asked, what are the symptoms? So Madam Roberts gave a very profound statement while she was talking about sometimes there are no symptoms. And if you have no symptoms, it's like hypertension, the silent killer. You don't know what you're looking for. If there's nothing to see, sometimes you don't know till you present to the hospital and you have that damage and the damage is already there. And then you say, well, I go into the hospital and the people tell me this and they ain't sure and they don't know what they're doing. But the reality is, unless you do your yearly physicals, unless you do your labs, sometimes you may not know. Okay? And thank you, Pastor. 28,000. So there is the risk of that amount of people with kidney disease out there. So we have a lot of screening to do. Dr. Mitchell, you have a lot of work to do. You have lots of feet to look
Yes.
at. Okay?
I just
Lots
wanted
of
to
feet.
also mention here that I Googled it and it says more than 600 persons are currently on government-funded hemodialysis program in the Bahamas. So that don't mean the private places, that's just the government-funded. Chronic renal failure is on an all-time high with approximately 200 to 250 new patients developing end-stage kidney disease annually. So it's a high demand for kidney services throughout the entire health system. And so
Mhm.
I think that's a good point that you just said that, sometimes we don't have symptoms. There are no symptoms until we get to that stage. So what can people do? So if there are not any symptoms, like you mentioned, one is that people get their physical every year, get your check.
You have to, I have to put the plug in there for primary care. You have to go
Yeah.
to the doctors and you have to have your visits, right? Because it may just be that blood test that shows that your creatinine, which is a mark of kidney function, or it is the BUN that is a mark of kidney function. And then again, so I just see somebody in the chat, and I think this conversation is real. They talked about obesity being at a high prevalence or incidence within the Caribbean, and truth. And if I remember correctly, there was something that was saying that we almost had the highest incidence of obesity in the Caribbean. And
Mhm.
not just obesity, and I think, and again, and I like to
Overweight
drop
also.
names. I love to drop names. So Dr. Christine Chin. So Dr. Christine Chin did some work with, and she did an obesity special diploma in obesity management. I think it was a diploma that she did. And it showed that incidence of childhood obesity is significantly on the rise. And why? It's our lifestyle. It is not just when it's not just our lifestyle, but well, I guess it's our lifestyle, but we don't cook at home as much as we do. We like to take them to the alternate places that should be treats and then become standard of our meals. So we have to be careful with that. So you talked about that 500 people or 500 or 600 people, and truthfully, that's a number that has been floating around for a while. And
Be
I
higher?
guess that's an easy number, yeah, from about 2 or 3 years ago, because so I'm sure that the number's even higher than that now. Okay.
All right.
Um, and truthfully, and again, I could speak to a public experience even more than I'll speak to the private experience. So we're in a dialysis unit at PMH. I'm not speaking as an agent of PMH at this point. This is just because I have knowledge of it. But we're in a unit at PMH where there should be no more than about 120 people. And I'm just saying that because 20 dialysis chairs, 3 shifts for the day, that's 60 people, and then 60 people for the next day, so 120. But we're doing 4 shifts with 20 people. So we have another 20, 40 people that really shouldn't be there. So we're up to 160 odd patients, almost 170, not including the people that are in hospital that have arrived at acute kidney injury and needed as well. So again, we talk about the great institution. but we just don't realize how much this great institution is bursting at its seams.
Yeah.
Because I say this tongue in cheek as I back away a little bit, because sometimes we don't take care of ourselves and do the things that we ought to do, i.e., our annual physicals to make sure that if there's anything that we could catch it. Even before that, we don't do, we're not doing the lifestyle changes that we need to do to make sure that we keep a BMI for a male under 30, for a male in neck size that is under 17 and a half, a waist size that is under 40. Females, the numbers a little different. BMI stays the same. I think neck size is then 16 and a half. And then waist, they talk about 36. Good. Because true, let's go back to your world, Dr. Mitchell, because all of those things are going to put us at risk of peripheral vascular disease.
Yes.
The more weight that we put on these legs,
And the more
the
they gotta
more
carry.
the more they have to carry, the more gravity is going to push down, the more you're going to have varicose veins, the more you're going to have the risk of diabetes with the ending vessel damage, the more we can give you work, Dr. Mitchell. You're going to have those ulcers on the feet, whether they're on the inside or medial ulcers or lateral ulcers or a combination thereof. You're going to have those corns, those diabetic corns on the bottom of the feet because you've damaged the
Pressure.
nerves in the foot and because of pressure again. And again, sometimes some people don't even know that they have damage to the bottom of their feet till somebody else tells them because you don't feel it. With the
Excellent.
diabetes,
That is true. True,
with the
true, true. A lot of
diabetes,
people
you don't
don't.
even know. I
They
and
don't
I
feel
talk
it.
in one of my I talk in one of my friends' business. So, friend, if you're on the internet and you're listening to us, my friend actually went to the pool, diabetic, lost a finger because of diabetes. So loss of limb, loss of digits, lost a finger because of diabetes. Went to the pool to have a good day out. Stood on pool deck, didn't realize that they walked in some of the powder that was there in the warmness, so had an acid burn to the bottom of the foot, and didn't even know that she had that they had the acid burn to the bottom of the foot till somebody say, "Mommy, blood coming from your foot." So
Yep.
again, ladies and gentlemen, we have to be very careful about what we do. Diabetes, and I'm going to go to diabetes because diabetes is the number one cause of kidney disease outside of now what we realize is the obesity and the dental caries or the non-communicable disease. So diabetes, listed as the number one, causes blood vessel problems, small blood vessels, big blood vessels. So vessels in the eyes, vessels in the brain, vessels in the heart, vessels in the kidneys, and let's not forget vessels in the fingers and the toes.
Mhm.
So kidney disease is real. Kidney disease is real with blood vessel problems, and with that, not just hand problems, the glove and stocking distribution, because you lose sensation to the fingers, you lose sensation to the toes, but then the whole thing about podiatry and not being able to sense what's on the bottom of your feet, pressure ulcers, the fact that you get an increase in infections around the nails, sort of niculitis, as we call them, the infections in between the fingers, it is real. So just something that we all should be very mindful of. I saw Dr. Mitchell, I see somebody in the group asked about protein. I love the cat, by the way. But and guess what? So that means even if you're diabetic or have kidney disease, your immune system goes off. So you even have to be careful about the pets that you have because cat scratch disease becomes real, eh? You get scratched by an animal and it doesn't heal very well.
So you
So
see
again, I
my
have to throw
cat.
that in there.
He likes excitement, so he's walking around. He hear all the talking. So
I
so definitely have you. So we see in the chat it says, I have heard that too much protein can cause kidney damage. Can damage the kidney. Is this true? And I don't know if they mean eating too much protein. So I think that's what they mean.
So by and large, I don't know that protein itself is going to cause the damage because if you have normal functioning kidneys, you should be able to pee out,
Clear it.
you should be able to clear it, you should be able to get rid of it. But I will say that if you already have kidney damage, that means that the body is going to lose protein because the damage to the kidney will cause that protein to leak out. Um, Pastor, there was a time when we used to say that we limit protein intake when people have kidney disease because they don't clear it, but we also know that could lead into this malnutrition kind of syndrome. So we don't limit as much as we used to. but we do talk about specific types of protein. So I think the whole concept is in poultry, turkey is supposed to be better than chicken. We know that poultry, we realize that that is the that's supposed to be better than beef. We realize that fish, high sources of protein, we like it, but that's because we like the omega in it, whether it's omega 3, 6, 9, whatever that omega is, because it acts as a wonderful anti-inflammatory.
Awesome. So we also have another question, a lot of questions about this protein. So when protein is found in the urine, does that indicate that there's kidney disease present?
So I'm going to say if protein is found in the urine, it means that it's spilling through the kidneys, and the kidneys are supposed to be able to block it off. Albeit, protein is also a marker. Protein being found in the urine means go look for the cause of why it's happening. So there may be other things that are doing, not just primary kidney disease, but something that has caused the kidney disease. Because again, a lot of the times, the kidney disease is a symptom of something else.
Good. So then it says to do, if you urinate a lot at night, is this a sign of kidney disease?
So that depends on age. So
Yeah.
sometimes, not sometimes, as we get younger in life, you will find that men, our prostate is going to get a little bigger, and so you're going to have you're going to have more episodes of getting up in the night to pee. However, what I would say is that getting up in the night to pee is more about prostate problems, or it's about laying flat. And I'm going to say more likely it is heart disease than it is kidney disease. Kidney disease typically causes that swelling throughout the day as opposed to just at night when you lay flat.
Mm. Okay. So again, I feel the answer to that one is going to be you need to see a doctor so they can
Please
figure
and
out
thanks.
exactly why you having that getting up a lot at night. Because like
Yes,
Dr. Smith said, a number of things could cause that. So Dr. Smith, I'm going to invite you to read this question in the chat by Norwich and see if you can give an answer to that one. And then I'm going to, while you read that, I'm going to ask that you expand a little bit more. And twice in your discourse, you were talking about your talk, you were talking about dental caries and kidney disease. Now, cover that a little bit, clear that up just a little bit more, because you know our dental care might not be as good as it needs to be, and we're hearing it now for heart disease, and now you're saying kidney disease. So, can you talk about that relationship for us, please?
sure. So whilst I'm trying to read this, because I'm a little challenged here. Eyes over 50, so it's a little bit much to read the small print.
We're gonna ask Dominic. So you answer the dental caries question, and I'm gonna have Nottage to answer that to speak to that question in a second. So to answer
Sure.
the dental question.
So what I'm thinking about with dental caries is, again, when we talk about dental caries, they say the mouth is the portal, right? So lots of infections. So it's the risk of those infections, the infection getting into the blood. It forms an antibody antigen complex trying to fight it. And when those things go into the bloodstream, they could go to the kidneys, they damage the kidneys. So it's almost like an infective kind of process. And because we're always eating, not necessarily always brushing our teeth, we're always throwing something sweet in our mouth and going to bed, not necessarily brushing our teeth first. So again, the dentist will say before you go to bed, use clear water or use water, wash out the mouth, get rid of some of the sugar. The sugar lingers there. It causes organisms to grow. In this case, it's what we call anaerobic organisms. So actually, it's everything, gram-positive, gram-negative anaerobes. So it causes everything to grow. The body has to fight it. It goes into the bloodstream. And when it goes into the bloodstream, you have those little particles that go into the kidney and can cause infection. With the infection, it can cause kidney problems.
Wow. I don't know if a lot of us knew that, but thank you very much for that as an encouragement for all of us to improve our dental hygiene, to just simply brushing your teeth, especially at night before you go to bed. I know it's an encouragement to me to be more vigilant with that. And so we're gonna ask Mr. Nottage if he can unmute his mic and ask his question if he doesn't mind, because it's a little bit.
Hello, can you hear me?
Hello. Yes, we can hear you. Go right ahead.
Yeah, dialysis patient since last year, end of August. And since dialysis, there has been like numbness in the feet. Anytime it's kind of manageable with the dry weight going low, but if I go too low, then I get other symptoms. They tested for diabetes, they tested for B12 deficiency, all were negative. So I'm just wondering what else could be the root cause of the numbness, and it's not the whole foot. It's just the toes to the balls of the feet on both feet.
So I'm going to, without being a nephrologist, I'm going to hazard a guess, and I guess it's a follow the story for me. So one, the first thing I would say with all due respect is that we have to figure out how you don't put on as much fluid in between your dialysis treatments so they don't have to take off as much fluid. So if you don't have to take off, so when you take off the large volumes of fluid, it will cause the blood pressures to drop for some people because it gives the body the sense that it's almost being dehydrated very quickly or for over a quicker period of time. So for me, because I have normal kidney function, I pee it out over time. So it's no real drop of a lot of volume at one time. So that's almost akin to cramping them. So what you're doing is you're losing fluid, and with the losing of the fluid, then sometimes again you become a little dry. If you become a little dry, there's less blood flow going to that area, and hence the numbness and the tingling that may happen. So that's just trying to put it into the context of this conversation without knowing everything else that's going on and without doing a over the phone consult. But that's one of the things that can happen when we take volume off or large volumes, just how the blood pressure drops. It means that you're relatively dry at that point, or you've taken blood away from the distal areas and it can cause problems.
Oh,
So
okay. Thank you.
if
Yeah.
if I could push that a little bit more. And I know, Dr. Mitchell, this isn't what we primarily came to talk about, but since
No
the
problem.
question is raised, it almost becomes akin to why we tell people not to eat on the dialysis machine. We tell them not to have meals on the dialysis machine because then what you're doing is shunting blood away from vital areas. You want the blood to go to your heart and your brain, but if you put food in the stomach, the blood goes to the
Go down.
stomach to help it churn and to digest, takes blood away from the brain and the heart, and hence the risk of chest pain or myocardial ischemia and the risk of stroke. So it's akin to the same thing. If we're taking blood from a particular area because they're large weight gains or the gain is more than we should take at that particular time, then you can get ischemic or you can get that pain. There's some things that we could do to try to change that, which are difficult in some of our settings. We could slow down the machines, or we could take the fluid off over a longer period of time. But again, not always possible because of the numbers of patients that are on the circuit or the time frame that we have you on for.
Yeah. Okay. Thank
I
you.
hope that's been a little helpful.
Yeah. Thank you.
Awesome. 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 So we see Jojo here has her hands raised, and we're going to invite them to ask their question at this time.
Yes, thank you. I would like to ask a question on the kidney. I know they say if someone drinks tap water that comes out of the faucet or pump water, like Bahamians always say pump water, they say it causes kidney stones. I wanted to know if that's true or is that a myth? Does pump water cause kidney stones?
So I will answer that a little different. The municipal water, which you can call tap water, the municipal water that we have here in the Bahamas is treated. Um, it is the calcium and that sort of thing is already taken out of it. So it is not as hard as if you're using water from a well that's not treated or you're using rainwater which is not treated. So we're not supposed to get stones from drinking tap water. In fact, to my recollection, tap water is actually pretty good water. It's treated well for bacteria, and it also takes out a lot of the hardness. Again, if you have well water, then it's coming up through all that limestone and there are particles in it. And if you notice, even if I guess I talk in my own business here, like even if like I have well water and I use it in the bath, so you'll notice that you have to use more soap to lather up the towel. And then if you use water that's coming from government water, you don't have to use as much. And then if you use water that's bottled water and purified, you have to use even less of the soap.
Yes.
So the well water or the well water is probably harder. The rainwater has a lot more of the chemicals and stuff in it. So they may cause some deposits, or if they cause deposits, they cause deposits more than the bottled water.
So yes, my husband is he just reminded me, he said, that water and sewage is constantly ranked between, I think, Akapio and Chelsea's in terms of their quality.
Absolutely.
And
Some of the
so it's a
best.
good quality water. And nowadays, Dr. Smith, the young people and the children, they all grow up on bottled water.
Yeah.
But the mature people like us grew up on tap water.
Oh, tap water. Tap.
And
I,
we don't have no more insulins or kidney stones and all those other things like that than anybody else. But I always marvel about that because it's completely different now. You can't drink tap water at all.
no,
That's the perception people have. But tap water is treated water,
it's
and
very
it's
true.
filtered water, and it's good water. Like I say, it's ranked between the two top brands that we think of at the top water in the country. So I want us to go into a little bit of a discussion about the dialysis patient and the feet complications. And I just want to read a little summary here so that we can preface this discussion. So dialysis patients face a significantly higher risk of severe foot complications, including a 5-fold higher rate of ulceration and increased amputation risk due to peripheral arterial disease and nerve damage that you already mentioned. So one of the things that we had advocated for was to have some kind of partnership or relationship between the podiatry services, which we no longer have at PMH, and the dialysis unit to be able to assess those patients and kind of make some kind of recommendations in terms of what can be done. So what have you been seeing or what has been seeing in the dialysis unit and in terms of the foot complications and this says 5-fold increased risk of amputation and ulceration due to the PAD that you've mentioned on several occasions this evening.
So what I'm going to say right off the top is whether it is done or it's not done, and this is not an indictment on healthcare services, but whether it's done or not, the assessment of the foot of a patient that is on dialysis is it's almost a part of what should be done every time they go on the dialysis circuit.
Mhm.
So that's just a standard. Now, whether it's done or it's not done is a different story. And again, that's not meant to be an indictment to anybody. Because just how sometimes we don't get to do it because of volume of patients, there's some patients who don't want to take off their shoes. There's some people that don't want to take off their socks. So you do have that sort of dynamic that we have to get over, or that culture that we have to get over where there's a taboo because the foot smells bad, the foot has an ulcer on it, and they don't want anybody else to know if it can get it off, how it can get it back on. We have to get over some taboos. And reality, it's just should be the standard.
Yes.
Um, I'm going to say that again, if we go back to the concept that diabetes, using the old data, that diabetes is the number one cause, they're going to have feet problem,
Yes.
right? They're going to have ulcers. They're going to have peripheral vascular disease because truth, if you have eye disease, it means that you have kidney disease. And if you have that microvascular, macrovascular complication, it means that you're probably going to have foot disease as well. Okay. So that is that's a component of that. We also know that lots of patients that are on dialysis, fortunately, unfortunately, have large ultrafiltration volumes each time. So what do I mean by that? They have to take off large amounts of fluid each time they come on dialysis. So if you keep putting on fluid that's greater than the 3 kilograms or the 6 liters, and we have to take off large volumes, it means that a lot of the times we have fluid that's left on. The feet is still swollen, hence you are going to end up with some foot challenges. The swollen foot that is perpetually swollen is going to end up with problems. It's going to become big, it's going to become taut, the skin is going to become thicker, it's going to become like shinified or thickened. You're going to have the risk of infections in there. You're going to have the problems with poor sensation because of blood vessel problems and then nerve problems. And in the same breath, if I'm trying to take off large volumes of fluid each time, we're going to go back to the same thing that could possibly be happening with the conversation that we had before. Where if I take off large volumes, it's a relative low blood pressure. So blood isn't flowing there as well. And so you're going to have ischemia and you're going to have ulcers. The other thing is, and you can't leave this out, the other thing is we don't particularly care to pay attention to dietary restrictions. We eat what we want to eat. And there's even this notion that I'm going to dialysis today so I can eat whatever I want, so because they can clear it anyways. So in my best politically correct green color, whichever school that represents, utter rubbish. Because if I'm putting a lot of phosphorus into the body, I'm not clearing it well. Phosphorus is going to bind to calcium. It's going to get stuck in the small blood vessels because it's not soluble. It does not break down. It's going to get stuck in the small blood vessels in the skin, and it's going to cause ulceration. So I agree with you, Dr. Mitchell. I agree with you, Dr. Mitchell. There is a role for podiatry in the outpatient dialysis centers. There is a role for podiatry in all of our renal patients, and hence our renal patients, and especially on their own, especially those with diabetes, hence you will see referrals coming, can you do regular foot care? The problem is once you give the referrals, it's up to the patient to go, and most patients do not go. They think it's an added on burden in terms of, well, I'm just thinking what they think, but I don't know. But they think it's an added burden of another visit. They think it's an added burden of another cost. One patient even told me we running a racket. But for me, the only racket I was trying to run was to save your toes, my buddy, my friend. But there is the risk of digit loss. There's a risk of digit loss in dialysis patients because of cholesterol. So the cholesterol gets stuck in the blood vessels, the small blood vessels, and you see the darkening of the feet. And if you don't correct that, then they end up with ulcers in the feet, and they end up with, would you say every second counts, with limb loss.
Yes.
So I think that
So
there is quite a big, we stick needles in their vessels every time they come to dialysis. So we have a catheter. We stick the needles in, where the needles go in, and if there's cholesterol plaques, there's a risk of those cholesterol plaques going to small vessels, and the risk of digit loss. So there is a high incidence of lots of things like that.
So definitely, like we've been promoting, and like I said, I with Nurse Roberts, Miss Roberts, I've had opportunity to go there twice to the Kidney Foundation Association meetings, and every time I go, I take the time to educate the members and to just answer questions and encourage them. Not only the persons on dialysis, but every diabetic, regardless of whether they're whatever, how long they had it. If you've had diabetes type 2 for more than 5 years, well, type 2 is right away. When you're diagnosed, that's when you come and you get your foot examined. For persons who've had type 1, after 5 years, that is when you begin your screening for your feet. So every diabetic should have their feet checked at least once per year. And because of the higher risk of the patients on dialysis, the five-fold rate increase of ulceration and amputation risk, they should be seen more often. They
Absolutely.
should be seen more often. And so we definitely need to continue to pump that message into them and to encourage them to get their feet checked. And when I go to the Kidney Association, I do a lot of education because I want to empower them to be able to look at their feet and to be able to say, they're not, most of them are not gonna feel it Okay, most of them are not gonna feel it because they have neuropathy, but at least if they are looking or a family member is looking, they may see something that may alert them to come and get help sooner and rather than later. And that is so critical to be able to do that. So we have one more question here in the chat to Dr. Smith. It says, I think this nurse Hepburn. She says, I have a friend who is on peritoneal dialysis and wishes to return to Nassau for a visit, a brief period. Where can he be facilitated?
So just before I answer Nurse Hepburn's question, I want to add one more thing to what you were saying. I take in prerogative now, eh?
No
Uh,
problem.
so I want to add something to your foot check. So I had a patient that came to see me, maybe it was last week, and the question that the patient had was, I need to go get a pedicure. I've not had a pedicure for a long time, and the patient is diabetic, and albeit well controlled. And I said to them, well, I don't think it's an issue if you're going to the regular spa and having it done. However, ideally, even pedicures and manicures should be done by a trained professional when people are diabetic and especially if they're uncontrolled, because one, we're cutting into cuticles all the time and the risk of not healing. Two, you have to be careful how much, and I think that I was told that they're called overlays or the acrylics. You have to be careful how you cut into the nail to put those things on. So even those things, they are trained healthcare professionals that offer that kind of service as well, so that we have less risk of infection, less risk of damage to vessels, less risk to the cuts and the poor growth of nails, less risk to the fungal infection to the nails. So even in that, I put in a plug, not trying to take work away from the traditional spas, but just suggesting that patients that are diabetic, patients who have any immunocompromised state, really should be seeing a podiatrist, even if they take the lead from that in regard to their foot care, and if you do it hand care as well.
So
Now
I
to
wanted
answer the
to just add to what you said because that's an awesome segue. We actually just I partnered with a nurse, Nurse Vashti, and we just began what we're calling Footworks Pedi Spa. And so that is a perfect environment for persons like that to come in. Not only would they get a quick assessment to make sure that they can receive that service, and if they cannot, then they will be sent back to the podiatrist, but they can also receive that service in an environment where instruments are sterilized. There's no soaking, so you're not having the risk of infection. You're getting an assessment, you're getting qualified people to be able to provide that service where you get your nails done or you get your calluses dealt with. And so definitely, for 20 years, almost 20 years now, I've been home and persons have been asking me about that. So we've just began, I guess, February or maybe February, I think was when they opened. And so I just put the number in the chat. So if you know somebody or if you need to come in, then that is the place that you would come and be seen. We recommend that persons, like all diabetics, should be seen at least once per year by their podiatrist. Like today, I saw, I think, 2 or 3 persons who were doing their annual checkup. So once they've had their annual checkup, everything is good. They got good blood flow. They have good sensation. Their nerves and everything is functioning. Then they can have their quarterly or how often they want their pedicures. They can go to Nurse Vashti and have that done in a safe and sterile environment where instruments are sterilized, just like we do at our office or they do at the hospital. A steam autoclave. The instruments are treated that way, and then everything is disposable. We don't have files and all these other things that persons use from one client to the next. Everything is disposable. The only thing is the instruments that are reused, are sterilized between each client. So thank you so much for reminding me of that. I put the number in the chat, but if you need some more information, you can always call the spa, or you can also call our offices as well. And I will put those numbers in the chat as well.
And thank you very much. And plug out and heads out. And sorry, well done, Nurse Vashti. Well done,
Nice.
Dr. Mitchell. So the other thing, so Nurse Hepburn was asking about peritoneal dialysis. So
Yes.
the center that I think does the most peritoneal dialysis in the country is Princess Margaret Hospital. And so we'd have to figure out how to get into Princess Margaret Hospital through the clinics thereabout. So you just have to reach out to the staff there. The director is Dr. Rhea Thurston. Not sure if the email goes through her or it goes through the one that is at the dialysis unit. And unfortunately, I don't have that on hand to offer it. But it's through the dialysis unit at Princess Margaret Hospital. The lead nurse there is Sister Roca, Darnell Roca.
Oh,
Two
that's
clinic
my
nurses.
colleague. We went to nursing school
Yeah.
together.
Oh, really? I forget
Yes.
he was a nurse. My Lord. Forget
I
them
don't
so
know
small.
why.
Yes.
Hmm.
So there's that. And then there are some of the private centers that will offer it. So there are numerous centers, and so that I don't sound like I'm being prejudiced against one against the other, even though I work in one versus the other. I'll say reach out, and there are centers. Yeah, yes, Sister Roca is. See, I can
Yes,
stop for
Sister
that
Roger
one.
is awesome.
He is awesome.
Don't worry,
Right.
I'm taking a picture of that, Dominic, so I can
Okay.
send that to her.
Okay. Now that's down. Lest y'all get me in trouble. There's some other awesome nurses in there, but we're gonna take Sister Roca. We're gonna take that one right now.
Yes.
Um, so there are private centers in the institution in the country that can help to direct towards peritoneal dialysis. The private kidney centers or the kidney centers that are there. Doctors, there's the kidney center, there's dialysis, the dialysis center Bahamas, there's Oak Tree, and there's Eden Wealth. That's the five that I can think of. There's Commonwealth. So that's the six that I can think of in Nassau.
Wow. I did not know that.
Yes.
Well, definitely, Nurse Hepburn. Definitely, you have a number of places that you can check and see exactly what could be done, because I'm sure they would love to come home and come get a little bath, sunshine, and see, but even if it's for a short time. So hope so. So I will agree, Sister Roca is awesome. Yes. So Dr. Smith, we're wrapping up. So I would like for you to somebody asked about calciphylaxis. Can you just speak to what that is, please? And then we will move towards our wrap up.
What was the term again?
I think it's calciphylaxis. That's like
Calciphylaxis. Okay, I got
yes.
that. Yes, I can tell you about that one. So, so the very first thing, the very first thing that I will say is the one of the biggest things that we can do to prevent calciphylaxis is our dietary changes. So what we have to do is eat a low phosphorus diet, because what calciphylaxis basically is what I was trying to explain a little before. We have phosphorus in the blood, you have calcium in the blood, they bind together. It becomes insoluble, so they can't break apart. So they go into the blood vessels. And because the molecule is there, what it does is it goes to the smallest end of where the blood vessel is. So it usually goes down into the capillaries of the blood vessels, the smallest ones, which is again, you know, this hard thing or this dark area, and then this hardness that develops in the small vessels or in the skin. You typically see it. You can see it in the top of the thighs. You could see it in the shins. You could see it in the tips of the fingers. But particularly, we see them in the legs or just on the shins. A lot of the time, we see the dark nodules that are there. They look kind of scary because they seem like they come as a little dark spots all over the place and get hard. And basically, that's what calciphylaxis is. The reality of that, though, is again, is a blood vessel problem. So that means if you have it in the legs and you've seen it on the skin, that means it's most likely in the heart or in the brain and other areas as well. So it's causing areas of ischemia. Again, we go back to that term ischemia, where you have blockage of the blood vessels, and the blockage of the blood vessels decrease in flow. You get decrease in flow of oxygen, then what you're going to get is areas that are devoid of oxygen, no oxygen going to the tissue. That means the tissues die, and if the tissues die, they create ulcers.
Right time, let's work on this thing.
Drumming, you could mute, please. Okay. You could find her. Go ahead, Dr. Smith. Go ahead.
Yeah. So what happens is, again, the calcium and the phosphorus form like what looks like, if for all intents and purposes, little stones, and they are little soluble things. They go to the small vessels and they cause lack of blood flow. With lack of blood flow, again, you get tissue death, whether that's inside the organ, like in the heart with a heart attack, in the brain with a stroke, or in the skin where it breaks down and causes ulcers. The way to prevent it in the first instance is to control your diet. So when we walk around and tell people they should not have certain things, it's not just because we want to take it away for ourselves. It's not because we just want to waste their money. What we want to do is we want to protect their organs and their skin, because bad food, i.e., the food that we like, the corned beef and the salt, not even sauces, the same sauces and those sorts of things, we typically say anything dark has a lot of phosphorus in it, although that's not a true, that's just a kind of concept, because we also know that dairy products that aren't dark, milk and cheese have a lot of phosphorus. Those things we don't clear very well. They bind to the calcium, they get stuck in blood vessels, and they give the risk of heart attack, stroke, death, as well as ulcers to the skin. So we go back to your part of the world, Dr. Mitchell, where they end up with breakdown in the skin, where they end up with issues in their toes. And the truth is, you could do all that you want to do to try to fix it. It doesn't get better till they have a dietary change. We give them some expensive medication to bring it down, or we dialyze them a whole lot more. And the patients don't even want to stay on the dialysis for the 3 hours. They don't want to stay on it for 4 hours, much less the 5 or 6 hours, 4 times a week that we may have to do it. So again, lifestyle change is best.
Dr. Smith, I must admit to you, I did residency at Mount Sinai, and one
Okay.
of my patients, I will never forget that. One of my patients, that's how I learned about calciphylaxis. I had a patient that had that, and to this is now 20 years later, and I still remember that lady and the case and everything, because that was so, it imprinted on my
Mhm.
brain so much that,
Yes,
it is really, really, and it's painful. So
it
I
is.
really, really, really remember that so much, but a lot of persons may not think that, it can affect them, but it can if you don't watch your diet. So we
Yeah.
have here in the comments before we get to the wrap up part. Great presentation, Dr. Smith. And she's from Rum Key, Nursing
I'm
Jane from Rum
impressed.
Key.
You
Put me
made
on
me
the list
international.
right now. I'm coming to Rum Key. That's one of my islands. And then we have one more question. It says, does tomato seeds cause kidney stones?
Now you caused me to screw up my eyes on that one, because that's the first time I've
I
ever
see
been
that.
asked
I
that.
see that.
I to answer that question, my lady or sir that has asked that question, I have never been asked that, and I'm not. So I can't say yes or no to that. But my answer is I don't think so. The only thing that I'm going to say about the tomatoes in general is, but tomatoes are full of potassium and they cause problems in kidney
So,
disease.
be morning.
Yes, yes. This is where you go back to what Pastor said in the beginning. Being a doctor means that you realize how much you don't know.
Yeah. So we're not sure about that one. We're gonna have to I'm gonna look that one up. I look that one up and make sure that we gonna get back to you. If you leave your number, that person who asked that question, I will look it up and get back to you. Okay? So, Dr. Smith, from the very beginning of our talk together, because we're getting close to the end, you spoke about lifestyle change. And I'm going to give you an opportunity to reiterate that, because not only does it affect the patients on dialysis who got high blood pressure, diabetes, all of these things, we need to imprint that on our brains to realize how important the lifestyle change is to everything. Obesity is
Everything.
like the number one thing in our country. Over 80 something percent of us are overweight and obese, almost
Yeah.
90% of us. And so just reiterate that and how important it is for us to think of not kidney disease as one disease. It's a spectrum, because the obesity and the lifestyle choices that we make, as a result of that, it leads us to not only kidney disease, dialysis, high blood pressure, all of these diseases that kind of culminate into the kidney disease and dialysis. So please just reiterate that. So we will go home with that on our brain and we can move towards that.
So what I'm going to say about that is almost everything that we talk about from a medical perspective, I think it always starts with lifestyle changes. Everything. If it's hypertension, it's low sodium. If it's, and that's the dietary component of it. If it's diabetes, it's decrease the carbohydrates. If it's kidney disease, is watch the phosphorus and everything else in the potassium in the diet. So everything begins with lifestyle. And lifestyle then not just includes diet, lifestyle then includes the type of the way that we live, i.e., stop living a sedentary lifestyle. It's called more exercise. Lifestyle means even in terms of the way we're living and we're sleeping and we're waking. So that whole sleep or circadian rhythm, you know, night is made for sleeping, even though we do shift work these days. Night is made for sleeping, day is made for working. It's when we eat, it's how we eat. So if I could leave one thing with you, the combination of all of those things and the way we live is, I think, one of the greatest things that we can do to change the outcome of the way of the way or how we're going to live, so to speak. So the way we live is going to change how we live, i.e., preventing the amount of medication we need later on in life, or decreasing that medication, decreasing the disease burden that we have. And again, that's it. That's the beginning of it all. Lifestyle changes, diet, exercise, sleep patterns, the things that we do not just with ourselves, but within our entire families, the way we cook, the amount of salt you put in the pot of rice. I think that whole lifestyle thing is where we need to start.
Excellent, Dr. Smith. Excellent. So you covered all the areas, our diet, our exercise, our sleep. Lifestyle involves everything we do, the water we drink, our mindset, the way we think and the stress that we carry. So definitely, I feel like this presentation has brought us full circle to back to where we began in terms of how important our lifestyle is. So before we leave, thank you, Dr. Smith. Excellent presentation. Thank you so much. I love this format. It was very good because persons were able to ask their questions and you were so relaxed and given the answer. And somebody actually said it here. They said, excellent, awesome information, Dr. Smith. You explained it with great simplicity. So excellent, excellent, very, very good. Turks and Caicos in the house. I think that's several persons from Turks and Caicos. So thank you so much for being here. So if you are interested in being a part of our Feet4Life group, just put your phone number in the chat, your name and phone number in the chat. We will add you to the group so that every month when we have in this meeting, we will send you an invitation. We're very happy that Mr. Nottage got it from somebody, some family member sent it to him. But please put your name and your number in the chat and we will put you on the list and you will get your own invitation every month. We usually meet on the second Thursday of every month and the login is the same. We do not change the login. I mean, we always send it because persons, it's easier to find. But the login information is the same. So you don't have to worry about that. The second Thursday of the month at 7 p.m. So we are actually going to be right back here on April. What is that second Thursday? Hold on one second. Let me look at my notes. It's going to be the 9th, Thursday, the 9th of April at 7 p.m. So we'll be right back here. I want to say thank you to Dr. Smith, of course, and then to everybody else who attended tonight. Wonderful, wonderful presentation and awesome opportunity for us to ask all of our questions. And we have a lot of persons from all over who were joining us. So we want to say thank you to everyone who was here. Tamika, who is the president of the Kidney Association, I understand. Ms. Lindiana Ramming, who is the president of the Diabetes Association. Now, you two need to get together. Ms. Ramming, you can just open up and say, give me a little wave. Give us a little wave, okay? Give us a little wave in the chat, Ms. Ramming. She's the president of the Diabetes Association. As we do that, we're going to invite Pastor Williams, sorry, to come now and give us our closing prayer. I don't know, but Ms. Rami maybe stepped away. So, Pastor Williams, you can give us our closing prayer at this time.
Okay. Thank you so much, Dr. Mitchell. Let's pray. Father, thank you so much for the time we have spent, the information that we have received. Dear Lord, put it within our hearts to apply it in order that we may be both holy and healthy, that we may be vessels that you can use because we would have taken care of your holy temple. Bless us now. Thank you for the presenters. Be with them also that they may continue to educate us, that we may live a happy, healthy, and holy life. In Jesus' name I pray. Amen.
Amen. Amen, Pastor. Thank you so much. I see a question in the chat as well, asking about where do they get the recording. So we do have a YouTube channel, and that YouTube channel is Feet, F-E-E-T, the number 4, Life, 242. So you know it's from the Bahamas. And on that channel, we will have all of our previous videos already uploaded. This one will probably be uploaded probably by weekend. And you can go there and watch the video and get all the information again. You can also go to our Facebook page, which is Family Foot Center. And I think it'll be there for, I think now they keep it up for like a month or so. But you can always go to that page as well. And so you would see the recording for this evening. Thank you all so much for being here. A wonderful evening and a wonderful presentation. Thank you, Dr. Smith. Thank you, everyone, for being here. We're going to leave it for a few more minutes. So if you need to put your number in there, we are going to collect all the numbers so we can add them to the invitation list. If you have any other questions, we'll be happy to answer them as well. I'm also at Family Foot Center. The number there is 605-3668. If you have any questions or you need to get in touch with anybody, then you can give us a call and we would be happy to do that for you. Again, thank you so much for coming.
Thank you for the invite, Dr. Mitchell.
You are welcome.
I will be speaking with you, Dr. Smith, in a little bit.
What is the number again for the Family Foot Center?
Okay, it's in the chat. We're putting it in the chat right now. It's 605-3668. That's Family Foot Center.
Good job, cuz.
All right, thank you.
Yeah, it's
The number
66
for
people
Footworks
on.
is 605-3338. Go ahead. I think I saw Dr. Horsley in. You are welcome. Thank you all for coming. Mm-hmm. You can call me.
Yeah, excellent presentation. I was trying to find them.
Thank you so much. Excellent job. Everyone did a good job.
Thank you so much.
You are welcome. You are very welcome.
Hi, Dr. Mitchell.
Hey, Liliana. You got all
Yes,
the numbers?
good evening. Yes,
Good
we
evening.
must
Thank you.
connect.
Thank you.
Awesome. You are welcome. You are welcome. See one more here too. See some more there.
Yes, we must connect, Dr. Mitchell.
Yes,
Renal and
you heard that she said
diabetes.
the soiree is sold out. Anyway, let's chat afterwards. I can call you.
Okay.
All right. Hello. What's that channel? What's that channel? Wow. Like yeah, like it's a joke. Oh, no, she's still on. Okay, good night, everyone. We're gonna close the room now. Oh, just one more minute. Yeah, you're taking gonna be the